cool cases. We'll do shock rounds today. We'll try and speed it up a little bit. But before I kind of dive into the background of these cases, I kind of want to go into just an overview of the Protect Duo. If you guys don't know, it's my favorite mechanical circulatory support device, and really because of just how many use cases you can have for the device. If I go too fast, please do stop me, and then we'll kind of go into more in depth into cool use cases for this device and why we should kind of consider future directions of research for this device. So, I'm presenting the Mighty Morphin Protect Duo. Really cool because many use cases of how it can be used. But before we can kind of dive into that, have to have some understanding of how the Protect Duo is designed, as well as how it's placed. So if you guys are familiar with some of the ECMO cannulas, like the Avalon Duo cannula, it's a dual lumen cannula. And because it's dual lumen, it's much larger than your usual mechanical circulatory support device. So like, really, kind of an overview, what does it do for the heart, right? Imagine it as like a tag team partner for the heart's right side. Like maybe like a relief pitcher in baseball, when the right side of the heart is tired and needs a break, the Protect Duo, you can place it in, and then it can take over. It has two cannulas inside. Like I said, similar to the Avalon cannula, but it's different in its positioning. It takes over by moving the blood from the right atrium, pumping it out, and then back into the circulation, into the pulmonary artery. Very different from all our other devices. This means the right heart can chill out for a bit. And because the blood's still flowing at like a solid pace, when you connect it to a pump, it functions as an RVAD. And you can get up to flow of like 4.5 liters a minute, which is pretty close to what the heart pumps on a good day. So when you add an oxygenator to it, which is that purple box, now it becomes an ECMO circuit, right? It's not just an RVAD. But instead of that classic VA configuration, where you're taking blood from the vein and inserting into an artery, you can call it a VP configuration because you're taking blood from the vein, from the right atrium, and then the outflow fenestrations are in the pulmonary artery, completely bypassing the RV to give it a break. Now, here's the really cool part. Because the setup is pretty, like slick with the cannula going at the neck and the pump being completely portable, these patients aren't stuck in bed. They can get up, they can move around, they can carry their pump with them. It's like, having freedom in a situation where you really expect to have none. And then, you have like these vests that the company has come out with to kind of support patients during therapy. So not only are you supporting the heart and giving that right side a break, but you're also getting patients in their feet, which is huge for recovery. And we use it for a bunch of situations, tricky heart surgeries, when the heart's shocked after these surgeries, or when, the right side is just plain giving up. And then for the researchers in the room, it's opening up doors to new ways to kind of tackle heart and lung issues, specifically in the transplant realm. Let's see. So you can kind of see like those inflow fenestrations in the right atrium. It's pumped out into, and then, plus or minus that oxygenator goes to that pump and pump back out and then into the pulmonary artery. So when you look at how this device works, I don't want that volume. Yeah, so you can gain access via the right IJ, you insert the PA catheter, and then advance into the PA. You're going to see in a second. Once you kind of get your usual access, and this is usually done under an echo or fluoro, then you insert your PA catheter, you inflate that balloon. So something, all of us should have experience with. Then you advance it into your pulmonary artery by basically floating it. And this is a specially designed PA catheter. The cool part about this PA catheter is now the next step would be is to insert a guide wire through that PA catheter. Then you'll anticoagulate the patient. Your goal ACT is around 400. And then this is where it gets, pretty gnarly. You start your serial dilations. These dilations can be French dilators of like 14, 18, 22, 26 French. It's one of the largest devices that we use. And so you're obviously going to have a lot of bleeding in these patients. Once you've adequately performed your serial dilations, then you'll go ahead and insert the cannula. The cannula has a introducer catheter in it. That's a white piece. You'll get it to the point using the markers and where the pulmonary artery is. You get a lot of bleed back as you introduce, as you remove that introducer and that guide wire. And you're really relying on those markers to make sure it's the right area. And then just like with any ECMO circuit, you start getting that blood flow back, you clamp it, and then you will do our whole water trick to make sure that no air enters the circuit as you kind of connect the two. And that's it. And there's that pump that we talked about. This one doesn't have an oxygenator connected to it. Really functioning as an RVAD device. So when we talk about the size of the catheters, I mean, this thing is huge, right? Like when you compare it to your other catheters, you know, we're inserting triple lumens, and that's about 5 to 7 French. Our trialysis catheters is about 12 to 13 French. And now we're really relying on the expertise of our, you know, vascular surgeons, because your Impella CP goes about, you know, 14 for the arterial versus 22 if you're doing the RP. And then for VA ECMO, you know, the going up anywhere from 17 to 25 French. But the ProTech Duo, because it has that dual lumen configuration, can be anywhere from 29 to 31 French. Pretty insane. There's also a rapid deployment ProTech Duo, which you can insert much quicker into the femoral. It's a much longer device, and that one's also 31 French. So, you know, really, let's talk about these configurations, right? We talked about the many opportunities of different ways you can use the ProTech Duo, and really cool device. So, you know, we'll theme it as like the Mighty Morphin Power Rangers, but really the Mighty Morphin ProTech Duo. This cannula can really morph into whatever you need to kind of like tackle these tough cardiogenic shocks scenarios. And whether we're talking like RVAD, LVAD, or full-on ECMO, the ProTech Duo can be really a huge resus toolkit, provided it's available. So one of the cool configurations, obviously, is the RVAD, right? When the right ventricle is like in a tight spot, say after a heart attack or a massive PE, you can insert the ProTech Duo and kind of give that extra support. Once again, just inserting into the neck or the leg, no big cuts needed, using echo or fluoro. And then the cool part about this is it can be deployed rapidly. You know, really just to quickly give the heart a break as soon as possible. And when you look at the studies in a series of like acute MI-related RV failure, 60% of the patients in that series made it past 30 days. And in the reported cases where thrombectomy was combined with a ProTech Duo after like a massive PE, all the case reports report a full recovery. But it's not, you know, not all, you know, sunshine and rainbows. There's risks like strokes, bleeding. And then when it comes to, you know, the amount of blood you have to use, it's, you know, like a vampire of a device, because you just, it can cause hemolysis, it can cause a profound bleeding, and you have to keep these patients anticoagulated. But it has a survival rate of 72% at half a year in the largest case series that I found, especially when it's used as a rescue device just at the right time. Next, you can really use it as an LVAD. It's been adopted for left ventricular support. So a team by Goodwin et al. Approached it with a minimally invasive thoracotomy. And what they did was they went through the apex, avoiding critical coronary arteries, to place the device directly into the left ventricle. You know, with meticulous guidance, they use fluoro, TEE. They position the ProTech Duo to ensure optimal blood flow, once again, achieving that 4.5 liters per minute, similar to a device like an Impella. But, you know, this device was kept in this configuration until the patient received a more permanent LVAD solution. The one, you know, case report where I found where they studied this, the patient after a while did end up dying of a stroke. This technique, using it as an LVAD, as like a temporary LVAD, is still new and requires further study, but it can be a potential for quick life-sustaining support until a permanent LVAD can be placed. Then, you know, finally, when you have like BIV failure, right? So when we talk about LVADs or left ventricular assist devices, like, you know, they can be a game changer for patients with severe heart failure, but there's a catch, right? So right heart failure can sneak up as a serious complication after LVAD complication, which leads to early mortality. So why does this happen? I'll get into this a bit more, but think of it as like a traffic jam. So the LVAD is pumping blood out of the left ventricle, but if the right ventricle can't keep up, the blood's going to back up and then cause that congestion and failure. And that's where a device like the ProTech Duo can come in. You know, you can team it up with an LVAD, creating that like that dynamic duo setup for BIV failure. And so how does this kind of like tag team work? Well, when you look at the studies of how they initially started by placing in patients who had a permanent LVAD, and then added on a ProTech Duo because of that LVAD was causing RV failure. They did like a 2-year study follow-up, and then patients were up and moving with an average of like requiring the RVAD support just for 2 weeks, and most were eventually weaned off the RVAD. And then there's another study that once they took this design setup, they had patients with patients who like decompensated right after LVAD implantation, and then you just put that Protect Duo in, and then like within a week they're back on their feet and the device is out. And then the cool part is you're not getting in the way of physical therapy during the standpoint. So then finally, you take this concept of using a uh, Protect Duo as RVAD support for the post LVAD patient, but now instead of the post LVAD, like the permanent LVAD patient, you use it for someone who's getting like the temporary LVAD, right? Like an Impella. So you take your Propella, or you take your Protect Duo and an Impella, and then you can call it like ECPella 2.0, which is like the ECMO version of the Protect, or you can call it Propella. And in this case, there's no thoracotomy because it's a Impella inserted venously. It's or through the artery. It's just a Protect Duo through the neck, and then the Impella via like a femoral artery or an axillary artery. And when you have that combination of the axillary artery with the Protect through the neck, once again, patients can like walk around and stuff, and they're getting BiV support. So another group like took the success, patients who had like a really dangerous high risk cabbage, resulting in shock, they stabilized them with this like ECPella 2.0 setup, and they even tried this in kids. Where they did a pediatric brain transplant using the Protect Duo to provide that RV support. So like when patients are facing this double trouble of LV and RV failure, this combination of like this Propella circuit can be really useful. So going back to that initial configuration of that sole RV support, right? When you add that oxygenator within that, prior to the blood getting to that pump, now it's not just a device that's doing that RVAD function, it's also doing the ECMO function, right? Because now you have the Protect Duo with an oxygenator, creating that VP ECMO that I talked about. And it's like giving the right ventricle a helping hand while ensuring that the organs also get the oxygen that they need. So the blood flows from the right atrium, gets the oxygen, goes to the pump, back in the pulmonary artery. Really good for the patients that have combined cardiac and respiratory failure. So, this was initially studied in patients with like severe COVID-19 ARDS. And what they did was they compared them to patients who were just being treated with mechanical ventilation alone. And when comparing the two, you had a significant drop in mortality from over 50% down to just 5.6% at 30 days. And the cherry on top was that there were 0 cases of AKI with this VP configuration of ECMO, versus like 71% with those that were treated with mechanical ventilation alone. And it's once again not just about like the overall mortality, but also the patients in this group had with the VP ECMO had a 73% discharge rate, with patients walking out without needing oxygen, and a mortality rate that's impressively low, really supporting the use of this ECMO configuration provided it's available in patients that are good candidates for it. Far more superior than just mechanical ventilation alone. Now, when we study it more, we realize that sometimes even this configuration of VP ECMO is not going to be enough to address those with refractory hypoxia. So then what you can do is you can take that standard venopulmonary position with an oxygenator, but instead add a second 25 French femoral venous drainage cannula for increased venous drainage. You combine the two using a Y connector, was like 3/8 inches or something like that, and then you inject that into the that membrane lung, that oxygenator. So really, the goal of this to increase the amount of blood flow through the system. The problem that they had with the circuit in the case series that I found is that despite this increased flow, the oxygen improvements were minimal with this configuration. So in this configuration itself, what the team did was they just modified. They thought on their feet and they modified it to a venopulmonary configuration, which was far cool. So what they did was they still used that cannula, but they only drained through the femoral, that 25 French femoral cannula, and then went through the oxygenator, went through the pump, and then using that Y connector, use both lumens of the Protect Duo to insert blood back, both into the source at the right atrium and the pulmonary artery. And this patient went from sustained saturations of 78% up to 100%. You also had notable improvements in flow from 4.2 liters to 7 liters a minute. And the reason for that is that you are getting about 4 point, when they did like, they put a flow probe, they saw that the distal port, the one in the pulmonary artery, was getting about 3 liters a minute. And that proximal port, the one in the right atrium, was getting blood about 4 liters a minute. So you're delivering total of 7 liters a minute of oxygenated blood, but you're reducing the amount of blood flow to the RV. So kind of safeguarding that RV function and allowing it to recover, but without having to compromise on addressing that refractory hypoxia. Really cool configuration. And then finally, where I think that for more research is obviously needed, but a lot of possibilities here is that like kind of like on this last journey of the different devices of different configurations, is that you can use it for both heart and lung transplant. So like imagine you're in the OR, there's a heart or lung transplant on the table. They need stability during this like high risk procedure. So what these transplant surgeons start to do is they'll place that Protect Duo device, and they'll utilize that dual lumen configuration. They'll put one group, what they did was they did central ECMO. They put a cannula right directly into the aorta, about like an 18 French cannula, basically creating that central bypass. And then now you're using that dual lumen to take blood out of the right side, insert it into the aorta, and then you can take out the lungs. And then another team copied this configuration and then used it for a heart transplant. And then another team after that copied this configuration and use it for both a heart and lung transplant. And in each of these cases, like for example, that initial one, once they implanted the lungs, they just took out that aorta cannula and then you switch back to just regular VV ECMO. Really cool stuff. So I want to go back to like the setting of BIV failure, right? So you are concerned that there's quite a few reasons of why you could precipitate RV failure after LV support. And we've seen this a lot with patients who are, initially receiving a Protect Duo, a permanent LVAD device, and then even temporary LVAD support, like such as through an Impella, right? So why does this really happen? And there's a few reasons of why this could happen in someone that's getting that LV support. So they could have pre-existing RV dysfunction, and then you're just bringing it out as you take away that extra work or add that extra strain using that LV support. So you've got like pre-existing right-sided failure, and then you just make it a lot worse. Or you're creating that extra afterload and exacerbating that pulmonary hypertension, making that right heart work way harder than it was before. You can also, just like your massive PEs, alter the dynamics between the RV and LV, create that septal shift, causing that decompensation. RV precedes LV failure, RV causes LV failure. And then finally, you have like a new device in place, right? That's going to cause a lot of inflammation. It's going to cause neurohormonal changes. And that's just going to cause profound cardiomyopathy that it can't keep up with from the right side of the heart. So keeping that in mind, that BIV setup or that Propella setup has a lot of support. And this is where I kind of want to go into the cases that we had. This is a series of 3 cases, all with similar scenarios. Kudos to Jared for making this identification. So 3 patients, a 57-year-old male, a second patient, a 57-year-old male, and a third patient, a 78-year-old male, all with likely comorbidities. The second one, very minimal follow-up, 3 different presentations. The first one comes in with recurrent VT, stabilized on amio and lido. The second one comes in with an out-of-hospital cardiac arrest. They bring them in. The rhythm is recurrent VFib. They've shocked them. They put them on amio. They put them on lido. Eventually get stabilized. And the third one actually had a catheterization done outpatient because they kept coming into the hospital for recurrent admissions for heart failure exacerbation. They diuresed them, but they never actually did a PCI when they did the left heart cath because it was too high risk. And they knew that this patient needed a CABG. They just had to optimize them first. This patient comes in with like full anasarca, scrotal edema, leg edema. They say, okay, you know what? Let's optimize this patient in the CV ICU, diuresis, milrinone, and when they're ready, then we'll go ahead and do the CABG. When you see these patients, you should obviously be thinking that this is all ischemic mediated cardiac disease, right? So all at some point, patient 1 and 2, within days after they arrived, underwent cardiac catheterization. And in the case of patient 3, already had known ischemic disease, but needed to be optimized. And you can see most had concern for multi-vessel disease. That patient in 2, had a concern for an LV thrombus also, which is understandable given the risk of, extremely low EF, cardiomyopathy in the setting of ischemic disease. So then what happens next, right? We go ahead and we do this initial ischemic intervention. Patient 1 and 3 underwent a CABG. And in order to maximize LV recovery, they gave it a break perioperatively by placing an Impella 5.5. Patient 2 had 1 stent placed, had a left heart cath done, received a drug-eluting stent, and then received our favorite dinosaur force to support them through this period, the intra-aortic balloon pump. And initially, patients for the most part came in somewhat stable. It's important to note like what kind of meds they were given in terms of anti-clotting factors. So All three received aspirin. Patient one and two also received therapeutic heparin. In the case of patient two, it was triple therapy because it had a new stent plus that concern for the LV thrombus. And if you're thinking what I'm thinking is that all of these patients decompensated, right? And why did that happen? It's because they all had profound bleeding. Things got really, really dicey. I think all our resuscitationists, they were all different physicians on, did a really great job, but really stabilizing them, advocating for further intervention, massive transfusion protocols. In the case of, all three patients that were found to have high output bloody drainage through either pre-existing chest tubes, the ones that had the cabbage, or in the case of patient two, our expert ICU clinician that was on utilized ultrasound, identified a large right hemithorax, drained it immediately as soon as they put that picture in, got 2 liters out. At this point, they're on multi-pressors, they're getting multiple blood products, and really could classify as, Sky classification D, if not E, um, due to what happened after they were resuscitated with all this excessive transfusion. So, kind of going back to what was happening with these devices, due to that blood loss, that Impella was obviously having recurrent suction events. When I'm trying to go back and see what was the max support that we were providing with these Impella 5.5s, it was quite a bit. And obviously, you can't maintain that, right? Because this is just a temporizing measure, but as you're sucking more blood out, you're not going to be able to keep that out because really the fix here is more blood. Um, and then, this is a classic circulatory support issue. As you are in this bleeding state, all that inflammation, that lack of blood is also going to likely cause the heart to take a hit. And now the heart's going to get into even more heart failure, requiring more support. So, the first and last patient, in order to address this bleeding, did undergo surgical re-exploration while all these meds that I talked about were held. And then, bleeding is a very understandable risk after cabbage. But on top of that, you have these like dangerous devices in that can cause hemolysis and things like that, and can possibly be a source of the bleeding. So the first patient on re-exploration had no source of bleeding. Everything was carefully looked at. Little oozing here and there. They addressed that. Being extra vigilant to make sure there was nothing missed. The second one, which was on triple therapy, was deemed all due to medical bleeding, likely from that triple therapy, which was held. And the third patient on re-exploration did have evidence of anastomotic leaks from the cabbage, a known complication. It was sutured up. It was addressed. Um, but let's talk about the transfusion. So how are these patients resuscitated, right? Hell of a lot of blood products given, right? I mean, in patient three, where they actually had surgical bleeding, 14 units of red blood cells were given. A lot of platelets, a lot of FFP. Patient one and three even got, the four-factor complex. So if you're thinking what I'm thinking is that with all this volume that was given, what part of the what organ is going to take a hit? And it's really that right side, right? All three patients developed refractory hypoxemia, extremely low PFs. Now, at this point, you're advocating for, you know, the ECMO support to address the oxygenation. In these patients, you're also seeing now evidence of RV dysfunction. Really profound in that patient. In the third patient, our expert ICU clinician actually recorded a TAPSE extremely low. You had the PAPIs, which measure right-sided can measure right-sided failure. The lower it is, the worse it is. Um, Once again, extremely concerning in that third patient. Really good solid finds by our ICU team advocating for additional mechanical circulatory support for that right side to our cardiothoracic surgeons who are all in agreement. So kind of going back to our initial setup, at this point, you have concern for RV dysfunction, creating both a profound shock state and oxygenation failure. Now that right ventricular assist device is needed to address the shock state, and now you'll put it in that ECMO configuration to address the oxygenation. In patients one and two, you've already got that Impella 5.5 in place, which for those, you wouldn't see that pigtail. But in patient two, knowing that in order to keep up with the flow through the RVAD, that intra-aortic balloon pump had to be exchanged for an Impella CP, and that's why you see that pigtail there. And then in all three, that Protect Duo device is inserted in that VP configuration. For patients one and three, it was inserted via subclavian site, and then for patient two was inserted via the IJ. And you can see that VP configuration with blood draining out of the right atrium through the oxygenator, through the pump, and then back into the pulmonary artery. So all three of these patients generally just all came out in extremis. The support that was being provided through these devices was up titrated. You can notice that the pump flow on the RVAD is maintained at about half a liters less than that from the LVAD device. Something you just have to know about when managing or having two devices in together. Um, Does that configuration overall make sense? So eventually, after giving both sides of the heart time to recover, all three patients made a recovery and had improvements in LV and RV systolic functions. You're basically giving these ventricles a rest through the device. The teams did a great job supporting these patients through these critically ill days. And eventually, as you wean down the support from these devices, you're seeing that you're maintaining an adequate cardiac output, enough to advocate for device removal. And for all three patients, these devices were removed. Both devices were removed. So what happened to all three patients? The first patient, was in the hospital for a while, eventually made a recovery, left AMA. The second patient was discharged to subacute rehab. The third patient ended up, being in the hospital for a while, getting trached and pegged, ended up going to LTAC. Um, so there you have it, right? Propella rescue in transfusion-associated bivalve failure. These patients were really high-risk patients with profound ischemic disease causing left-sided failure. They were supported through with a left-sided device. All had profound bleeding complications. Our intensivists did an expert job resuscitating them, but because of excessive transfusion, all went into profound RV failure, refractory hypoxia, really requiring that rescue with two devices, or that Propella configuration or that ECPella 2.0 configuration. So, kind of in summary, these cases really highlight the critical role of a Propella device, and this configuration in managing complex scenarios of ischemia-mediated LV cardiogenic shock, especially when complicated by this bleeding that you're seeing that causes RV failure after excessive transfusion. But in these cases, the timely introduction of the Protect, the Impella, really helped stabilize them. And when these patients were like in Sky D or Sky E, all of them made a recovery. And I really say that it kind of underscores like the importance of vigilant monitoring for RV failure in these patients, especially in the setting of like high bleeding risk. And really, I think as an intensivist, advocating for more of an anticipatory approach when considering deploying that second device for RV support. Um, and like in the paper that we're going to try and publish, really advocating for refining more models that would predict when you're going to have RV failure so that you can more advocate for like in anticipation for when you'll need that second device, really being more proactive about this. And then this way, overall can lead to like better outcomes, reduce morbidity or mortality. And then even when you're just considering insertion sites, considering it in a way that doesn't get in the way of patient mobility. And there I have it. Anyone have any questions?